So what we're talking about here is craniomaxillofacial trauma. These are approaches that can also be used for oncologic surgery as well as aesthetic surgery. Facial trauma is not just orthopedic surgery. You can't just make a big incision and throw in a plate or some pins or something. We've got facial aesthetics to deal with. We've got to deal with the facial nerve as well as sensory nerves, which makes it a little bit more tricky. Okay, so the goal with just about all of these incisions is avoiding neurovascular structures and optimizing cosmesis. You need to use as long of an incision as necessary. The question is just how do you hide it? So you try to optimize the skin tension lines, and you need to be careful of hair follicles as well if you're up in the scalp with the bicoronal. So just as an overview, we're gonna spend a good bit of time on periorbital approaches, the subciliary and transconj approaches. The bicoronal, those are the main ones that give people the biggest amount of difficulty. And again, if you have questions along the way, just chime in, please. This is always an odd format. And then we're going to talk a little bit about transoral approaches to the maxilla and midface. I don't know if you guys got this, but there is actually an AO-sponsored webinar with Larry Cunningham and Steve McLeod tomorrow. I don't know if we can forward you guys that link. They're covering similar topics. And are certainly outstanding faculty, and I recommend it, but this will do for now. So periorbital approaches, getting to the orbital rim, getting to the orbital floor to fix zygomaticomaxillary complex fractures as well as in any panfacial approaches. First, we're going to talk about the subciliary incision. Again, all lower lid incisions are skin muscle flaps. In other words, if this is the skin and this is the periorbital muscle, you're raising this flap regardless of whether you're coming in through the conjunctiva or through the skin. You're always raising this and coming down along the septum if optimal. You can cheat and go in behind this, but then the fat is everywhere and it's kind of messy. So if you can stay over the septum and raise a skin muscle flap, that is the preferred technique, whether it's a subciliary incision where you're making your incision here and raising your skin muscle flap, or you're doing a transconj incision where you're going through the septum and then getting back out into that plane. Okay. And the reason for that is the orbital septum is contiguous with the periosteum. That'll lead you right to where you want to be as far as your fractures go. It's also, these approaches can also be used for blepharoplasty because that gets you to these fat packets, which is what is saggy and poochy and what we're going for from an aesthetic standpoint. Okay. So once you've got exposure, the goal is to get this bone exposed. Fractures tend to go right through the infraorbital nerve just because where the hole in the bone is the path of least resistance. So it's more likely to fracture right through it. But whether regardless of the incision, this is the end point. And as you go laterally, you've got some other smaller nerves, which we don't always worry about. But this is the big one that you're concerned with. The other thing is, as you're coming along the floor, you got to remember when you're lifting up the orbital contents, the infraorbital nerve is along the floor and that actually stays down. So there's a plane of periorbita that gets lifted up. The nerve stays down. Okay, so a subciliary incision, you can raise it as a skin flap. It tends to get a lot more edematous that way. It's a little bit of a stepped incision. In other words, you make your incision just under the lashes, and then leave a little bit of muscle and then drop down onto the septum. So you're about 2 millimeters below the lashes, okay? You can extend this laterally and strip the skin and muscle off the tendon. You don't need to do a canthotomy. It's kind of what's called a pseudocanthotomy. And so that helps a little bit with the closure, because the hard thing when you're doing a transconjunctival incision and you're doing a lateral canthotomy, the repair is easy except for the canthal tendon. And so the advantage of the subciliary incision is you really don't need to deal with the canthal tendon, but you do have a greater risk of ectropion. So that's the downside. So once you've made your incision 2 millimeters below the lashes, you're going to enter through the muscle and get down to the septum. Okay, so here it is in cartoon view, where basically you've made your incision up here and there's a little bit of a step. You don't need to come right through that. If you go through the muscle too high, that scar will contract, and that's what gives you your ectropion. And so you want to stair step it just a little bit. It's only a couple millimeters, but you don't want to overdo it and come down here, but you want to step it just a little bit, and then you're going to elevate off of the septum, and that'll take you down to the periosteum. Okay, so there's your septum there, and then you can incise either with a knife or a cautery down straight on the bone, which you can feel at that point. You get a lot more lid elevation with a subciliary incision. It's very nice access. It's just a scar on the face that if you can avoid it, you should. Okay. And so then you can get down onto the floor and elevate the orbital contents up, deal with the floor, deal with the fracture, good access. Okay. The alternative, which is a nice incision, particularly for aesthetic surgery, is the transconjunctival incision. It's still a preseptal dissection, like I said. Basically, what you need to do in order to get to the front of the septum is go through the septum. So your incision is actually down. You want to come down, and what'll happen is you'll retract this a little bit and put a little bit of gentle pressure on the globe, not too much, but what that does is pooches this up a little bit so you can get on that. And it's a very thin, you can do it with a cautery. But you want to turn it down. You want to have it at like 10 or 15 and use a Colorado tip or another fine tip type cautery to get down there. And then you've made your incision. You'll need to incise the septum, which is right under there. It's not uncommon to come through the conjunctiva and the septum in one pass because this is so thin. So you just need to be careful and not get carried away. You can do a transconjunctival incision and get exposure to the majority of the orbital rim and certainly all of the floor without a canthotomy. The canthotomy is what makes this, it's not the incision that causes the aesthetic problems with this approach. It's the repair. And so if you don't need to get laterally, you can extend this incision pretty much all the way across. You're limited a little bit medially by the lacrimal system, but not much. And so you can get to the majority of the floor without a canthotomy because that's what makes it look, it gets very pulled if it's not done correctly, and you get a very aesthetic defect, if you will. But again, all approaches are skin muscle flaps just over the septum. Okay, so you've made your incision and you can come all the way across here. Okay, you don't need to do a canthotomy, and I would say probably 5% of the approaches I do a canthotomy, and those are generally severe fractures where you can't get, where there's a fracture between where if you would do a lateral brow incision or something, you need to reduce it here. and the majority of this. So it's really just for fractures that kind of wind up right in this window that have the canthal tendon attached to that loose fracture if you've got mobile bone here. But you can come all the way across here. And once I've incised the conjunctiva, I'll usually just pick up the septum and start snipping at it. There's usually already a hole because it's hard not to go through the septum with this incision, and then just come across as you elevate this up. And then what'll happen is he's got stitches. I'll just use a double prong skin hook for this elevation. And then once you've identified the septum, because you'll keep grabbing it and re-grabbing it, I'll just throw a stitch through this segment here to retract it up, and then start pushing it out of the way with cotton tip applicators, and then eventually like a malleable retractor. And then you can put your DeMar or your eyelid retractors in to hold this out of the way. Okay. And so, and this illustrates, it's not the end of the world if you miss the septum and you're raising a skin muscle flap with a little bit of orbital septum. It's just when you do this, fat starts getting everywhere. It gets a little bit cumbersome and messy, but don't beat yourself up if you miss. Either way, you're going to be able to get down to access what you need, and you're still staying out of this periorbital conduit. You're just getting into the fat, and so you may need to address that. And an older person, they'll like it because you can cauterize some of it or take some of it out. Okay, so again, sometimes there's a lateral extension of the fracture, or you just can't get it reduced without stabilizing it to the skull, and so you may need an external incision, which you're going to try to camouflage either on the lid or laterally towards the eyebrow. Okay, and so these are for these higher fractures where this is really comminuted. Again, if you've got a fracture up here, that's one thing. If it's down here, that's where you're going to wind up needing your canvotomy. Okay, but for these where you just need a plate and you just can't get it right, or this is not stable with an infraorbital or a transoral incision and your orbital incision, you just need something else to get 3-point fixation, you make an incision, and it just runs just below the brow. Try to put it along the axis of the hair follicles. Okay, and it's not a big incision. You're probably going to get like a 5-hole plate on. In other words, 1 hole across the fracture and then 2 on each side. It's not a big incision, and it really does. It only gets you to one place. This is the only place it gets you to. It's not for definitive orbital repair. It's just if you need that last little bit of stabilization. Okay. The alternative to that is to put it on the upper eyelid. Basically, you put it in the lid crease. It's even more limited incision because then you're basically retracting to get out over there. But this is basically where you would put it. It doesn't show it well here, but if you were putting in, say, a gold weight or something like that, you're coming in the lid crease where they've got a just kind of a wrinkle, and then elevating that up over the supraorbital septum. But then you can camouflage it here. This is basically you're cutting right down on the fracture, and it heals very well. They can camouflage it with makeup if they need to, or they just don't care. But it's another alternative, so you have less scar on the face. And some of it has to do with anatomy. If they've got really big orbits, this isn't going to get you where you need to be. This is well tolerated. The lateral brow incision is pretty well tolerated, but this is an alternative. Okay, and so again, you've got a lot more elevation, you've got a lot more retraction, and you've got a lot less access. So there is a trade-off. It does heal very well if you can get to where you need to be, but that's a judgment call. Okay. So now let's get to the bicoronal, which is kind of everybody's big concern because it's a great big incision. It's got a little bit of morbidity to it, but not if it's done correctly. Okay. And you can see here just on this, you can, if you either dissect out, you can drill it out, you can curette it. Most of the time you can just bluntly take it out with the with like a Freer elevator or something, and you can just push the supraorbital nerves out of the way. You can get a tremendous amount of access, and it's not uncommon to need to do this, particularly for nasoethmoidal fractures, as you can see here. Okay, but it gives you wide access to the upper half of the face. Basically, you can get to the zygoma all the way to the rim. And so you're not going to need that lateral brow incision if you've got a bicoronal. Alternatively, you're not going to do a bicoronal if it's just an isolated periorbital fracture. And so, again, bicoronal is a very well tolerated, very surprisingly inconspicuous incision, except in the completely bald. It hides in the hairline. You can put it as far back or as far forward as you need to relative to the hairline. The biggest issue is the nerves, dealing with the frontal branch of the facial nerve as well as the supraorbital nerves. And so this is your little acronym for the scalp. You've got skin, subcutaneous tissue, the aponeurosis, locerular layer here, as well as the periosteum. And the important thing to realize is that the facial nerve is actually in basically what winds up being the superficial, it's just over the superficial temporal fascia. The deep temporal fascia, which was protecting the orbital fat, is contiguous with the periosteum. And so if you're elevating up in this plane and you've got the fat pad deep, you're actually in pretty good shape for the facial nerve, but it's always, this is not as thick as you'd like it to be, so it's always something you're going to be careful about. And I'll show you where you're going to come in to stay and keep this out of harm's way. But it's very easy. And so there's two ways to raise this flap. One is to get down on the periosteum and leave the periosteum down, which will protect the facial nerve. And then you've got a pericranial flap, which you may need for a frontal sinus fracture, cranialization, or something like that. I actually prefer to go through the periosteum and just elevate the whole thing. If I need a pericranial flap, I can elevate it off the skin flap just as easily, because what that does is it puts me straight down on this plane here, okay? So if I've elevated the if I cut down onto bone and I elevate off of bone, I'm immediately on this plane, so I'm already out of harm's way here. And then we'll just cut through here to give myself A, access to the bone, and B, a little bit more safety away from this guy. And so, again, the temporal branch of the facial nerve traverses inside the deep layers of the temporoparietal fascia, not the temporalis fascia. The temporalis fascia proper is what keeps the temporal fat in place, okay? But it's contiguous with the periosteum of the skull, okay? So again, if you're elevating the periosteum, you're on this plane here, okay? So here's your skin, your sub-Q, aponeurotic layer, which is where this is kind of sitting. And then you've got the periosteum here. So if you're on this plane here, what you'll wind up doing is then down here, if you cut into the neurosurgery, if you need to get into the brain in a hurry, they'll frequently just come right through here. The problem with that, the upside of that is that, well, it's safe. You can stay away from this, no problem. They get a lot of wasting. They look very cachectic, and if they're otherwise healthy appearing, it's a little bit unsightly. So if you can stay out of this for the majority of it, you have to enter down here. But if you enter down here, this doesn't atrophy to the same degree that it does if you cut in superiorly. Okay, so again, here's your periosteum, your deep temporal fascia. As your periosteum of the skull elevates up, you can see you've got an extra layer of protection. And so you basically will palpate until you're on the superior aspect of the zygoma, and then you'll cut straight down on it. Okay, and as you cut straight down on it, you can start elevating your bicoronal skin flap forward. And as you do so, you can continue this dissection kind of in a outward or anterior means, and then you're going to get on the supraorbital skull superiorly, cut right down on that bone, and that'll just, you'll work kind of back and forth until you expose the whole lateral skull. And so you can see this is elevated superiorly here. You're basically cutting down. Here's a supraorbital nerve here, frontal sinus fracture repair. But you're cutting down on this bone and elevating straight up. You can actually see the nerve kind of in the deeper fascia here. It's not that clear, but it's there. And so if you're on the bone, you're 2 fascial layers away from the facial nerve. So you get pretty wide access there, okay? So you make your incision. Again, we'll sometimes spend a lot of time keeping people's hair out of the way. I don't like to shave anybody if I don't have to. If they've got a receding hairline, you can make your incision more posteriorly. If they've got a lot of hair, you can come forward with it. It doesn't matter. But you'll usually, because of the zygoma, and if you need to get access to this part of the facial skeleton, you need to extend this incision down almost to the tragus. You need to be slightly below the zygoma. If you're above the zygoma, then you're operating in a hole down here, and it's actually riskier, and there's greater traction on the nerve. So don't hesitate, because if you think about it, if you're making if you're doing a parotidectomy, you're extending this incision all the way up here. So there's really not a lot of risk to the facial nerve with that portion of the incision, because the nerve is going to come out and it enters right about here. So this incision is fairly harmless and is going to give you the access to this part of the facial skeleton, which is what you need. And I'll go straight down to bone here. And as you elevate periosteum here, you'll encounter the temporalis muscle. And if you're on bone and the fascia, the deep, thicker fascia of the temporalis is still down, you're in the right plane, and you can just bluntly push this forward. Okay, and that'll give you pretty wide access. You can actually get to the condyle if you really need to. Wouldn't recommend a bicoronal for a condylar fracture, but you can get there. Okay. Questions? Okay. So now we're going to change tacks a little bit. Some of the easier incisions conceptually, but there are a few pitfalls as far as the transoral incisions to the maxilla and the mandible go, that just make your repair a little bit easier. Not only your fracture repair, but your incision repair. These are contaminated wounds. They're in the mouth. They have a high likelihood of dehiscence, and so anything you can do to optimize your repair is preferable. These are they're just a few simple techniques that I hound on as far as these go. So to get to the maxilla, you're basically, both of these transoral incisions are gingiva buccal sulcus incisions that allow access to the middle third, basically, of the midface. When you're making these incisions, there's two key points. One is you want to leave, the tendency is to want to go right in the sulcus, just on the teeth line, because it looks accessible. And the problem with that is mainly that you need something down here, because you're going to have, the case is going to end eventually, and you're going to need to close this. So always make sure you leave enough, make your incision a good, healthy, almost, probably not quite a centimeter, but at least probably 7 or 8 millimeters away from the true sulcus. So you've got something to sew to here. Now, once you've made this incision, in other words, your incision is going to be perpendicular to the mucosa. Once you've made your incision through the mucosa, you want to turn, you almost need to change your cautery position from almost 90 degrees, because you want to go straight down to the bone once you're through the incision. If you don't, you're left with this cuff of muscle that's in the way of your plates. You can't quite see what you need to do. You need to elevate it down, and it makes the access to the bone difficult. And so keep a lot of mucosa perpendicular to the mucosa, and then turn and go perpendicular to the bone. So there really shouldn't be a shelf. If you've got a shelf of muscle here and a shelf of muscle here, you're gonna, it's just, you wind up needing a bigger incision because you get less access to the bone. And so same thing with the mandible. You need a nice wide cuff of tissue here. And so once you've made this incision, you don't want to keep the tendency is to keep dissecting through here, and then you're going to have kind of this angled shelf of muscle. You want to turn and go straight to the bone. If you do so with the mandible, that does two things. One, it gets all that soft tissue out of your way, number one. Number two, you can pretty much make this incision with reckless abandon, and if you turn straight to the bone, you're not going to cut the mental nerves. Okay, if you keep skiving down and do this at an angle, you'll run right into them. Okay, so some people, for comfort, once they go through the mucosa, will go straight down the bone and start to elevate up until they see the nerves and then open it up. But you can make this whole incision. And if you go straight, because if you turn and then you're going back to the roots, remember the mandible is, the mental nerve is going to be it's going to be below the tooth root. So if you head straight to the tooth roots, perpendicular to the bone, you're going to stay away from the mental nerve. Okay, and that's what you don't want to avoid. If you keep angling down in the direction of your mucosal incision, you'll cut right through these suckers, and you don't want to do that. And so this is a nice illustration. He doesn't have that a significant amount of soft tissue shelf there. So if you cut straight in here, you're going to come in above the nerve, and then you can elevate things off from there. Other than that, they're pretty simple incisions relative to some of the other aesthetic approaches. Okay. And you can get pretty wide access. You can get to the whole mandible. You can get to the subcondylar region. The issue from here, unless you have a significant amount of retraction, I don't know that I ever really get this access to the point where you've still got to put your screws in this direction, and so you may need a little stab incision for a transbuccal approach to get your screws and stuff in. But you can put your plate in here and you can reduce the fracture, easily get them into occlusion, but you can get pretty wide access here. Okay. When you can't go transorally, and again, comfort with the transfacial incision is important, because it doesn't matter how aesthetically pleasing your incisions are, a bad fracture repair is going to be A, problematic, and B, much more aesthetically disfiguring. If you get the bone right, the rest of it you can deal with. We can deal with scars. We can't deal with malunions, non-unions, bad fracture repairs. So go with what you know will work. If you need that access, particularly, quite frankly, if you're operating by yourself, if you have a bunch of assistants and you can put a bunch of transoral retractors in, you might be able to go a lot farther with a transoral incision. But if you're out on your own and you need access and you don't really have any help, you might have the scrub tech and that's about it. Don't hesitate to use a transfacial approach through the neck, okay? So we'll talk a little bit mainly about the submandibular approach, because this is the workhorse incision, also known as a Risdon incision in maxillofacial trauma. The technique is similar to what's known as the Hayes-Martin maneuver in head and neck surgery. It's the same thing. We'll cover the retromandibular approach and the rhytidectomy approach. Not a big fan of the rhytidectomy approach for fracture repair. Basically, you're trying to camouflage an incision that then necessitates either retromandibular or submandibular techniques. Okay, and so the issue at hand is that, well, here's your mandible, and if all we had to do was cut straight down on the mandible to get to the angle and get to the condyle body, it'd be fine. It's this marginal mandibular nerve that always made facial fracture repair is easy if it weren't for the facial nerve. And so the key is going to be to take through these venous structures and elevate it up so that you can get on the inferior border of the mandible, because then once you're on the masseter, the nerve, as you know from doing parotid surgery, if you're on the masseter, you're below the parotid. And so conversely, if you're on the masseter inferiorly, you're elevating the nerve up. So the key is to get down to the inferior border and elevate all of this tissue up to keep yourself away from this. And so you'll wind up doing that as a landmark. One of the landmarks of facial nerve anatomy for parotid surgery is that the marginal branch of the facial nerve runs superior to the posterior or retrofacial vein, okay? It's one of the ways, if you're dissecting out retrograde, you can find this nerve because you can follow you can identify the vein and go from there. So, but if you get under the vein, you'll start elevating this tissue up, and then you can get on the inferior border of the mandible and you're safe, okay? And so this is good access to the body. You can extend this anteriorly because here's the submandibular gland. And again, the object is to avoid this. We want to get to this, avoiding this. And so basically what you wind up doing is once you've gone through your skin and your platysma, you're now on the superficial layer of the deep cervical fascia, which, as you know, invests two glands, two muscles, two spaces. So the trapezius and the sternocleidomastoid, the parotid submandibular gland, the masseteric, and the suprasternal space of Burns. We're not going down to the space of Burns. That's down by the thyroid. But the principle is, once you're on the superficial layer of the deep cervical fascia, the nerve is invested in this. Just like up on the zygoma, the nerve is invested in the same layer. It's the same layer. You can technically, if you want, elevate all the way up to one and then come inferiorly to the other. That's a little excessive, but it's the same plane that we were talking about with bicoronals, except we were up here. And what you do is you identify, as you're getting on the submandibular gland, you identify the facial vein, ligate that. That'll elevate up. You'll identify the facial artery, ligate that. And what that does is, as you elevate this skin flap, that takes the marginal branch out of harm's way. The submandibular gland drops down, and so then from here, you're able to get on the inferior border of the mandible, elevate the masseter up, gives you wide access to the bone as far as you need, okay? So your incision, I'll generally make it a little lower. It's still 2 finger breadths below the mandible. The lower you make it, the bigger your incision. But if you need more access to the mandible, you're probably better off making it a little bit lower and a little bit bigger. Again, these are scars that are well tolerated in head and neck surgery. They're just as well tolerated in fracture repair, and a bad fracture repair looks worse than a scar on the neck. Okay? So once you're in here, you've ligated the vein, you've ligated the artery, you're dropping the gland down, And now you are not on the front surface of the inferior border of the mandible. You are on the inferior border of the mandible. You're almost under it. You don't need to go behind it, because that'll actually lead you astray and you'll start elevating the pterygoid muscle off posteriorly, and you don't really need to do that. And so, but you want to be straight on the inferior border of the mandible. So once you're on the inferior border of the mandible, you start elevating this up, put your retractors under the masseter, and that'll get you pretty wide access to the bone, okay? Retromandibular approaches always sort of scare me as a head and neck surgeon because, again, we've got the facial nerve in play. And so the object is to come right through here, more posteriorly, which is fine if you're including that as part of your submandibular approach and to get a bigger incision. And that's what I'll wind up doing. If I need to get up higher, I'll extend my submandibular approach posteriorly and include this, because then I've already elevated these branches out of the way. What they describe in a classic retromandibular approach is just this higher posterior incision, okay? So again, personally, I'll include it with a submandibular approach, and that just lifts the whole facial nerve complex out of the way to get to the mandible. But this is described, and you can see this section, how you get through these branches with reckless abandon. It's sometimes beyond me, but it's a well-described approach and is used regularly by particularly oral surgeons, which is fine, and they get good results because you're basically dissecting down between branches of the facial nerve through the masseter and parotid down to the mandible. This gives you higher access, but I still don't feel comfortable knowing what I know about the facial nerve and how it's coming out right here, that this is out of the way. This incision, again, if you've already taken control of the facial nerve, and this is just completely my bias, I'll make a bigger incision this way. That way I know I've got the facial nerve complex out of the way. Got wide access, you actually get wider access to the mandible and body. I don't use nerve monitoring for my facial fracture repair, and probably for that reason, I think if I went straight through a retromandibular approach, I probably would, just because I would be nervous about it. So I don't use it much. The Rhytidectomy or facelift approach is not a great access, primarily because it's a skin or a skin muscle subsmass flat. You're still not down to the bone. Now, if you're including it as part of your access for a bicoronal and getting further dissection so you can go more severe, this technique is fine. But you're still going to have to convert this either to, once you're here, you're going to have to do a retromandibular approach. But to get to the true angle, you're still not down to the bone. So I don't get a lot of bang out of this, but it's described. And usually it's just if I really need to extend a bicoronal, usually for oncologic surgery more than anything. The skin is a facelift incision, and from there, basically, it's a retromandibular approach. They're going straight between the branches of the facial nerve. I get nervous doing that. It's basically a more theoretically, aesthetically pleasing retromandibular incision, but the access isn't a whole lot better than the retromandibular approach, and you just got to cut straight through the parotid. So I don't really advocate these last two approaches, but we describe them just because you'll hear about them and you'll think about them. But I personally, and this is completely my opinion, not a big fan. And I think that's what I have for now. I left a little bit of time for questions. If anybody has anything, please chime in. Otherwise, we're done a little early. Okay. Thank you very much.